Everyone, welcome back to Saturday's afternoon session of the ABSITE review course. We'll try to stay on time, and again, promise to get everyone out of here by 5 o'clock, at least on the East Coast. Just a quick reminder, if you do have questions at all, and this is for those in Zoom, during any of the lectures, please put them in the Q&A section of Zoom. I've seen some posted in chat as well, but for the most part, our faculty and I will be answering those questions in that Q&A section. All right. Any other difficulties or questions, again, feel free to send us an email or post them in that Q&A section. But without any further ado, our first session of ABSITE Potpourri. It's everything you don't really want to study, but is tested on the exam. And I broke it up into two kind of separate sections. We'll do another one tomorrow, focus more on kind of the basic sciences, stuff that they might test you on. But for today, I thought we'd go kind of head to toe through our subspecialists and stuff that the American Board of Surgery thinks is important to general surgery residents in their training and tend to test on in ABSITE. Again, some of these stuff seems minor and we tend to gloss over it in our studies, but they still account for in total about 50 questions on your exam. All right, so start from the top, anesthesia. Right? Accuse, blame, and criticize anesthesia. But no, we'll go over their job role and what's important for you on the exam. So first thing, rapid sequence intubation, the first step is pre-oxygenate, right? Oxygenate, oxygenate, oxygenate. Then you start with inhalational agents. They like to test on kind of the indications for each or the side effects of each. For halothane, the biggest side effect or that they're going to test on is hepatitis. So you'll see jaundice or increased LFTs. Sevoflurane, you can use these more in peds. It's got a fast onset, less pungent, and causes less laryngospasm. Isoflurane used in neurosurgery because there's no increase in your ICP. I haven't seen that tested in years. The most important one that they like to test on is the following. Which inhalation agent has the least myocardial depression, fastest onset, and used in the dentist office all the time? That's nitrous oxide. So they give you some kind of cardiac patient that they want to use an inhalation agent, think nitrous oxide. All right, moving on to the IV induction agents. As your next part of your rapid sequence intubation, propofol. So frequently used because it's got a rapid onset as a sedative, but remember it has no analgesic effect. The most common side effect is going to be bradycardia, hypotension, and respiratory depression. This is all dose dependent. Prolonged use can also be associated with hypertriglyceridemia, metabolic acidosis at high doses as well. Etomidate, another frequently used one by anesthesia. That's because it's got fast acting and associated with the least changes in hemodynamics, right? You're not going to see that bradycardia or hypotension that you might with propofol. But side effect wise, it is associated with adrenocortical suppression. There is debate in the literature whether one dose really causes it or not. You can certainly see it with higher doses or continuous infusions. Nevertheless, if you see a question on the exam asking about induction agents and some kind of adrenocortical suppression, they're hinting at etomidate. Ketamine, old drug, coming back into vogue and more frequently in our practices, especially in the emergency department. And that's because it has a rapid onset of amnesia as well as analgesia, right? So that's the downside of propofol is there's no analgesic effect, but you will get that with ketamine. Again, dose dependent, lower dose is good for just pain. Mid-range, you kind of get that conscious sedation from 0.5 to 1 milligrams per kilogram. You'll get a little bit of an amnesia effect or partial dissociation, get general anesthetic doses once you go over 1 mg per kg. The good thing is it's got no respiratory depression and really no increase in your ICP. Historically, we thought it increased your ICPs, but that has been proven otherwise. Again, what's going to kill you in TBIs and elevated ICP is hypotension. So if you have this borderline patient that you need to give an induction agent, think ketamine, right? That hypotension is going to be far worse than an even minimal or perceived increase in your ICP. Downside of ketamine, again, at those higher doses, you'll get that dissociative effect with hallucinations, some increased oral secretions, potentially an increased cardiopulmonary demand. Neuromuscular blockade agents, most commonly used is depolarizing. There's only one of them, right? And that's going to be succinylcholine. It's got the fastest onset of about 60 seconds. You see it fasciculate, and then the side effect you want to monitor for is hyperkalemia, which is why we avoid it in our end-stage renal disease patients. And on the test, they may give you the stem of a burn patient with crush injury. Again, some people will debate it in the ER. If all this happened within the last hour, then you don't have the hyperkalemia develop yet. It's still okay to use. Again, a bit of a gray area. They're not going to give you that kind of question stem on the ABSITE. In terms of non-depolarizing, there's a few different options here. So the way they're going to test it on the exam is the time of onset or how it's metabolized. So rocuronium has a fast onset of about 75 seconds, metabolized by the liver. Pancuronium is going to be your slowest or longest acting. So pan, I think, kind of worldwide and big and just slow to get around, and also long lasting. Cystatricurium, also known as Nimbex, a relatively slow onset, somewhere in the middle between your rock and your pancuronium, but nice because it has Hoffman elimination. So it could be used in those patients with liver and renal failure, a little bit more predictive metabolism of that drug for you. In terms of reversal for these neuromuscular blockade agents, it's the anticholinesterases that act indirectly by increasing the amount of acetylcholine available within that neuromuscular junction that gives you that prolonged paralysis. Sugamidex is the only selective relaxant binding agent in clinical use, and much faster than neostigmine, also much more expensive than neostigmine. The first muscle to recover from these paralytics, first is the diaphragm, the last is the neck, which is why sometimes in the OR you'll ask anesthesia to ask a patient if they can lift their neck off the table. That means your paralysis is worn off. Right? The most important thing to do is breathe, which is why the diaphragm comes back first. Malignant hyperthermia, hopefully you'll never see it. This is an anesthesiologist's worst nightmare. And this is a kind of syndrome of life-threatening muscle rigidity, fever, acidosis, and tachycardia, and can result in severe and life-threatening condition, usually related to general anesthesia medications. The most common one is going to be succinylcholine, but has been associated with other inhalation agents as well. What causes it, or what's the pathophysiology behind it? Excessive release of what from the sarcoplasmic reticulum? Calcium, right? And even if you didn't know that, just a good test taking strategy there. Excessive what coming from muscular tissue that I know clinically leads to rigidity, right? So calcium makes muscles contract. Just, again, test taking strategy as you're trying to recall or think of these blanks. The first sign you'll see is a rapid increase in your end tidal CO2. Not always fever necessarily, right? Because they may be hypothermic a bit in the OR. What's it caused by? An autosomal dominant genetic mutation. They're really reaching for things if they ask you this, but it's always fun to pimp the residents on this. The RYR1 mutation, or ryanodine receptor mutation, is the most common. Treatment is now I've subliminally enticed you all to go get Dunkin' Donuts and coffee at the moment. But the reason I put it up there is you'll always remember the treatment D and D. First, discontinue your anesthesia medications, and the medication is dantrolene. Again, this is going to be an antagonist at that ryanodine receptor, so it decreases the calcium available to those muscles. And you want to cool the patient down, and ultimately recommend a muscle biopsy and genetic testing of the whole family so no one else has this. ASA classifications, you could drive yourself crazy trying to memorize all these, but it is fairly frequently tested. I'd say at least every other year, they'll give you a patient scenario and then ask you what ASA classification they are. So here's how I would approach it. Just try to boil them down into little groups. So for ASA2, these are just kind of your usual comorbidities, right? A little overweight, a little diabetes, a little hypertension, but mostly well controlled. ASA3 is going to be your more severe comorbidities, your coronary artery disease, your end-stage renal disease, but nothing recent, right? They've been medically stable for at least 3 months. They're on regular dialysis, et cetera. ASA4 is probably all the patients on your EGS or acute care surgery censuses. These patients have your severe comorbidities and uncontrolled or recently ill. Then there's 5. These are your unstable patients, trauma patients, class 1, running to the OR. There's also a caveat where you can add an E to any of these for any emergent procedure, but I've never seen any anesthesiologist do that. Cardiac pearls. I think they are getting away from the cardiac questions in general. I haven't seen these recently, but we'll go over these quickly. The most common benign tumor of the heart is going to be an atrial myxoma. The most common congenital heart defect overall is going to be a VSD. Good thing is that 80% of these close by 1 year. The VSD can also happen after an MI from septal necrosis. And the way they'll give you that in a stem is they'll tell you a patient had a recent MI, and now it's day 5 or 7.5 because of that tissue necrosis. You now have a new hollow systolic murmur. What happened? They developed the VSD. In terms of coronary artery disease, this is the most common cause of death in the United States. In terms of revascularization options, PTA and stent give you a 90% patency at 1 year. Saphenous vein grafts, a little bit better at 80%. have 5 years, but what's the best conduit? Ladies love the Lima to the LAD, LL. So Lima to the LAD, that's going to be your best conduit. That gives you a 90% 20-year patency. All right, aortic dissections. This involves a tear in the what layer? Intima, correct. Some people argue media. No, the blood ends up in the media. But what actually caused the dissection was that tear in the intima. Right? Different types, and Dr. Uppett will go over this in a little bit more detail tomorrow in our vascular lecture. But type A involves your ascending aorta, kind of must operate generally. Type B does not involve the ascending aorta, can be medically managed in your descending aorta. Cardiac tamponade, Beck's triad. Never seen it clinically in person, but it always pops up on exams. The hypotension, dilated neck veins, and muffled heart sounds. Best diagnosis is going to be an echocardiogram, ultrasound, fast in the trauma setting. We talked about that earlier this morning. They may give you this question in a post-CABG setting. Patient develops cardiac tamponade. Your option is going to be emergent re-explanation in the OR if the patient still has a pulse. If they have no pulse, you crack their chest at the bedside. Right? They're too unstable to move or anything else. You got to relieve that tamponade or obstructive physiology. Congenital cardiac abnormalities. I hated embryology in medical school. I still hate it today. But they like to test on these structures, right? 3 most important ones being the ductus arteriosus. It's going to go from your descending aorta to your left pulmonary artery. Ductus venosum going to bypass your liver for the left portal vein to the IVC. Foramen ovale shunts your blood from the right atrium to the left atrium. And then we go to congenital cardiac abnormalities. The most common complex one that exists is the tetralogy of Fallot. People have different mnemonics for remembering it, but I always liked this kind of drawing here. So pulmonary stenosis then leads to right ventricular hypertrophy, and then really it's the VSD and the overpowering of that right side of the heart that causes overriding aorta. But you get a right to left shunt from these defects, and the way toddlers or infants overcome it is by squatting. And why is that? What does that do? Right, increases your vascular resistance to try to at least temporarily overcome that shunt. Good. All right. What would you say is the most common early congenital cyanotic heart defect, typically presenting in the first week? When you have to treat more immediately. Transposition of your great vessels. Right? Medically treat it with prostaglandin to keep that PDA open, but generally a more early surgical repair. Coarctation of the aorta. This one clinically, you're going to have the different blood pressures in the arms and the lower extremities. In the question stem, again, they give you the most common scenario, and that's going to be an association with Turner syndrome or the 45XO genetic mutation. Treat that with resection of the coarctation area, and that's most commonly what? Yeah, at that PDA. If they ask you anything anatomic in the heart, the answer is almost always PDA. All right, thoracic anatomy. Blood supply of the trachea, they love asking blood supply questions. So in the upper 2/3, it's going to come from your inferior thyroid arteries. And as we go into our endocrine lectures and everything else, so the inferior thyroid arteries really kind of supply everything to the neck and upper chest. Lower third is going to come from your bronchial arteries. Thoracic duct runs along the right side of the mediastinum and then crosses midline at what level? A little bit variable, but yeah, or some people say a little lower, but T4, T5 is going to be your most common. And then ascends towards the left neck. Question they love to ask is where does that thoracic duct then drain or empty into, right? And that's going to be the junction of your left subclavian and your internal jugular vein. Keep in mind, when entering the chest, that the phrenic nerve runs anterior to the pulmonary hilum. The vagus nerve is going to run posterior to that pulmonary hilum. Branch of the vagus nerve that they love to test on is the recurrent laryngeal nerve going up towards the neck. Remember that recurrent laryngeal nerve innervates all muscles of the larynx except which one? Begins with crico, ends with thyroid. Cricothyroid. The left recurrent laryngeal nerve loops around your aorta. The right loops around your innominate artery. If they ask you the most common side that is non-recurrent or doesn't loop, that's going to be, again, on the right side. So the right recurrent laryngeal nerve is the most likely one to be a little aberrant. Other thoracic factoids, we'll say, is your pneumocytes. There's two types. The first one, type 1, plays a role in your gas exchange and oxygenation as oxygen diffuses through the alveoli. Type 2 does what? And this is what's damaged in ARDS. We'll go into this a little bit more detail in our surgical critical care lecture. Surfactant, right? Helps keep it open. Good. So clavin anatomy, kind of two areas of the body I'd say that are very high yield in terms of reviewing for ABSITE are going to be your neck and your groin. They love to ask the relative position of everything. So going anterior to posterior, clavicle, then your subclavian vein, right? And then your anterior scalene sits behind your subclavian vein. Sometimes they like to ask the phrenic nerve. How does that run along the anterior scalene? Right, lateral to medial. Behind that is your subclavian artery and then brachial plexus, and behind that, your middle scalene. Lung volumes and capacity. It's like a surgical intern's rite of passage to have to draw this out and label everything. But the first box here, expiratory reserve volume. What else makes up your functional residual capacity? Good, residual volume. One question that they do like to ask is about aging and how does aging affect your lung volumes? Actually, it increases your FRC and it increases, but the way it increases your FRC is by increasing your residual volume. It's just because your lungs get weaker, thinner, and tighter, right? It's the only thing that really improves with age is your residual volume, and it's not a good thing, right? The biggest thing, they flip it and say what decreases, that's going to be your FEV1, right? That's what really decreases rapidly as you age. You'll have a slight increase in your residual volume and subsequently your FRC, but ultimately you're going to drop your vital capacity because your total lung capacity doesn't change. All right, the single best predictor of post-op pulmonary complications. Just mentioned it. It's on the line below, right? FEV1. Generally want this higher than 0.8 or 40% predicted. Other more advanced things like the diffusion lung capacity of carbon monoxide you can use as well. So if that FEV1 is close or borderline, you could also consider doing a VQ scan to try to see how much of the planned resected lung is actually going to be involved postoperatively. Causes of a decreased diffusion lung capacity, lowered capillary surface area, lower hemoglobin, increased dead space from obstructing cancers, pulmonary hypertension, and a low cardiac output could do it as well. Again, you don't want to perform a resection if your preoperative PCO2 is greater than 50 or your PO2 is less than 50. Some would even say 60. All right. Lung cancer staging. I hated this chart as a resident, and it hasn't gotten any easier since. Again, you can kill yourself trying to memorize all these, and on your thoracic or cardiothoracic rotation, you certainly are. But in terms of ABSITE, I think it's helpful to kind of group them together anatomically, because the way they're going to test you is how do you biopsy these lymph nodes in this area, right? They're going to anatomically tell you, or they're going to give you a number and want to know what's the best approach to get a biopsy in this area. Right? So mediastinoscopy, or now there's also endoscopic fancy bronchoscopy with ultrasound. Those are going to be better for your centrally located tumors, right? That's going to be stations essentially 1 through 4 and 7, which is kind of subcarina. If the mediastinal nodes are positive, then your tumor becomes unresectable. A Chamberlain procedure is a small left mediastinotomy, kind of a mini thoracotomy, and that's going to be used to access what station nodes? 5 and 6. 5 and 6. So think of Chamberlain procedure or a left anterior mini thoracotomy, think stations 5 and 6. What makes it unresectable? Extrathoracic metastases, SVC syndrome, if you have a contralateral lymph node, laryngeal nerve involvement, or a malignant effusion. Things that are not contraindications are actually involvement of the chest wall, because you can resect that. Diaphragm, I say in the book, I find that one questionable, and pericardium as well. You can resect portions of the diaphragm, put it back together, and you can take out the pericardium as well. Ipsilateral mediastinal lymph nodes are not contraindications, as you can dissect and resect these during your primary lung resection. Pancoast tumors, You're going to resect, but only after doing what? Right, chemoradiation, you want to shrink it. We'll go into that in a few slides. Shrink it first and then resect. Kind of high stakes territory. It's like tire country up there at the apex of the lung. It's kind of like your porta by the liver. All right, lung cancer factoids. It is the most common cause of cancer-related death in the US still, about 20 to 30% of all cancer deaths. Risk is proportional to your history of smoking. That's the biggest risk factor by far. You can drop it a little bit by quitting smoking, but it never returns back to baseline. The most common type of lung cancer is adenocarcinoma, just like pretty much every other cancer. There's going to be females and peripheral. The strongest prognostic indicators can be the lymph node involvement. Most common site of metastases. Brain first, yep. Non-small lung cancer can go to the liver and adrenals as well, but most commonly the brain first. All right. Small cell lung cancer, these are going to be neuroendocrine tumors coming from Kolchitsky cells. These tend to spread early because they divide rapidly. So generally, by the time these are diagnosed, they're not resectable. Treatment's just going to be chemoradiation, surgery rarely an option. As we mentioned before, malignant pleural effusion makes this unresectable disease. Squamous cell lung cancer, again, is usually central, whereas the adenocarcinoma is peripheral. Paraneoplastic syndromes, small cell, what's that related to? An increase in what? ACTH, sometimes ADH as well. So that's going to give you what kind of presentation in a question stem. Don't overthink. Elevated ACTH causes Cushing's disease. Squamous cell, PTH, and how's that going to present? Right, PTH involved with calcium regulation, so they're going to be hypercalcemic. So give you a hypercalcemic patient in the question stem, think squamous cell. Most common paraneoplastic syndrome is actually from the small cell, though. Overall, again, you'll rarely see these in practice, but you'll always see them on the exam. Right? It's just fun stuff like this that's actually testable that they put on ABSITE. Mesothelioma, aggressive local invasion, frequent nodal invasion, distant mets, pretty bad prognosis overall. Usually tied to asbestos exposure, so they'll sometimes give the occupation of the patient in the question stem and what, right, shipyard or some kind of industrial worker. Tumors of the chest wall. These can get a little bit confusing. I'm not really sure why though. Most common chest wall tumor overall, not sarcoma, but osteochondroma. Once you include the sarcoma in there, so chondrosarcoma, or some people will say osteochondrosarcoma, but it's the sarcoma is a malignant chest wall tumor. If they just say any chest wall tumor overall or benign chest wall tumor, that's going to be osteochondroma. So sarcoma is the differentiator there. Pancreas tumors, I mentioned before, usually present with what? Right, that's Horner syndrome, ptosis, meiosis, anhidrosis, and that's related to invasion or compression of the, not necessarily, right, that stellate ganglion of the cervical sympathetic ganglion. Good. Yeah, they love that on step 1, step 2, and they love it on ABSITE too. This is usually going to be a non-small cell lung cancer. Can even invade the chest wall apex as well. You're going to treat it with neoadjuvant chemoradiation, then followed by surgery. SVC syndrome. This one can get a little bit confusing, and it's important here again to pay attention to the question stem. Most commonly, it's going to be caused by lung cancer, and usually small cell. Small cell, we said, is usually treated with chemoradiation, right? Not surgery. So acute symptoms, and I don't know how acute this really presents, but head and neck fullness and swelling, dyspnea, dizziness. They get that blue head, puffy head. Treatment, as we mentioned, is the same for treatment of small cell emergent radiation therapy. It actually does respond pretty quickly. Conversely, you might see a question stem about more chronic SVC syndrome, often due to fibrosis or scarring. And what kind of patient are they going to present usually in that scenario? Not an athlete. You're thinking of something else, which we're going to talk about next. What causes scarring or fibrosis centrally? Not sarcoid. It's usually kind of a end-stage renal disease patient that's had multiple lines, dialysis catheters, that kind of stuff. That leads to more of that central scarring. So treatment for that is going to be mechanical and opening it up with a stent. Okay, so pay attention to the question stem there if they're trying to get you to stent something or emergent chemoradiation. Adjuvant therapy for resectable lung cancer, probably beyond the scope of ABSITE, but typically carboplatin and Taxol for your non-small cell lung cancer. And then radiation after resection is debatable, decreases your local recurrence of the lung cancer, but no change in survival overall. Empyema and bronchopleural fistula. So empyema most commonly related to a previous pneumonia and now an infected parapneumonic effusion. They'll give you some pleural fluid samples, give you some of these diagnostics, and you'll have to try to figure out if it's just a simple effusion or malignant. So, or not malignant, sorry, empyema, infectious. Things to look for: elevated white blood cell count greater than 500, pH less than 7.2, glucose less than 2.2, because the bacteria have kind of ate up all the glucose, is how I usually think of it, and an elevated LDH. 3 different stages to it: exudative, fibroproliferative, or fibropurulent. And then there's also fibroproliferative. And then ultimately it gets to organized, right? And that's really when things get kind of socked in. So the earlier you get to these, the better. And that's why the treatment overall is a little bit controversial. But usually early, you can treat with chest tubes to drain it, antibiotics, plus or minus intrapleural TPA and Dornase. They give you the option to do them both together, right? Because that increases your drainage and your output. If the lung does not re-expand, then consider decortication. Other places will just do early decortication, which again is kind of a gray area. So I don't think they'll necessarily test you there. They're frail, elderly, refractory to conservative treatment. Consider an LOSer flap. It's one of the most morbid procedures you ever see. You literally just resect a portion of the chest wall and leave the lung open to air. Ugly. You'll see it once and never want to see it again. Bronchopleural fistulas. Treatment of this is to minimize your airway pressure, right? The more PEEP you have, the higher your airway pressures, the more you're stenting open that bronchopleural fistula. You want to minimize your airway pressures, right? Get them off the vent, or you have to keep them on the vent. You may want to use a different vent strategy like high frequency ventilation or the oscillator. It is a contraindication to rib plating because you're going to continually have this kind of connection with the bronchi and potentially infect your plates that you're putting in. So if they're asking for a contraindication to rib plating, they're probably hinting at some kind of infection or bronchopleural fistula. Chylothorax, a milky white fluid high in lymphocytes and what? Triglycerides, good. The most commonly most commonly caused iatrogenically after thoracic surgery or trauma. If it's not iatrogenic, then it's probably cancer, right, that evaded into it. So for a malignant chylothorax, you want to treat that by treating the cancer, usually chemoradiation. You could do some talc pleurodesis as well to try to seal off that area. Injury of the thoracic duct above T5, T6, or T4, T5, that's going to result in a left-sided chylothorax, whereas if it's below that, it's most likely going to be on the right side, or intra-abdominal if you're down there as well. Conservative treatment first, right? Try some diet modifications, MPO, TPN, no lipids, right? Plus or minus octreotide as well, and try to decrease that triglyceride output. Chest tube drainage if it's in the chest, obviously, as well. Surgical treatment if it's refractory to that. So you want to ligate that thoracic duct. It's usually low on the right side of the mediastinum. You can have an option of having IR try to bail you out and them doing lymphangiograms and embolization. They really track it up through the feet. Very low success rates, but is an option if you have a really hostile chest, something that you don't want to go in and try to find the injury. All right, hemopneumothorax, talked a little bit about this during our trauma lectures, but you can observe it if it's less than 300 mLs. Again, a controversial topic. I don't think they'll ask you exactly how to treat it on ABSITE. If anything, they're probably trying to hint towards early VATS, right? That's been proven. The earlier you do VATS, the better. Retained hemothorax is going to be your #1 risk factor for empyema after trauma, and that's what we're trying to avoid. Spontaneous pneumothorax, usually due to a bleb rupture, treat initially with chest tube. Surgery indications, which would be what? Failure to resolve, good. Recurrence, good. There's 2 more I can think of. I guess, but that's usually not a spontaneous pneumothorax. high risk profession, right? If they're going to be a pilot, athlete that might have more trauma or impact to the test. The other thing is if they have tension pneumothorax on presentation, that would also be an indication for surgery. And surgery again is VATS blebectomy with a mechanical pleurodesis. Thoracic outlet syndrome, and we'll review this in a little bit more detail in tomorrow's vascular lecture, but important to thoracic as well. The most common nerve distribution in neurogenic thoracic outlet syndrome. Anyone? Be ulnar, right? Or your C8, T1. So I just think of kind of your little finger or fourth, fifth fingers, numbness, and that's going to be your C8, T1. Tinsel test, tapping reproduces the symptoms there. For neurogenic, you're really going to recommend physical therapy first, right? And try to work through it. If that fails, your nerve conduction velocity is still decreased, then consider a first rib resection. Surgery is more involved for subclavian vein thrombosis, right? This is the vascular side of thoracic outlet syndrome. Also known as, Alyssa mentioned this before, Paget von Schroeder disease or an effort-induced thrombosis. Someone's doing repetitive motions like a pitcher or a swimmer. Symptoms there are going to be a painful, swollen blue limb. Diagnosis, ultrasound, say venography is the gold standard. I think that's historical, probably an old textbook. Duplex ultrasound nowadays. And no one can get out of hospital without a CAT scan, so probably a CTA. Treatment acutely, they say catheter-directed thrombolytics, usually if it presents within the first 2 weeks. Otherwise, it's a little bit too organized. And the treatment is to come back another day to fight it. So anticoagulation for 3 months and more of a delayed first rib resection. And again, we'll talk about the nuances of that a little bit more in tomorrow's vascular lecture. For esophageal potpourri, again, let's talk about blood supply, cervical esophagus, inferior thyroid, right? Always inferior thyroid. Thoracic esophagus is going to come from your aortic branches, the abdominal esophagus, off your inferior phrenic artery, and left gastric. I have seen the inferior phrenic artery be asked before. Diffuse esophageal spasm is a strong unorganized contraction on manometry, or nutcracker esophagus is going to be really high amplitude peristaltic contractions. Those are a little bit shorter in length or episode compared to your diffuse esophageal spasm. But either way, they're both treated with calcium channel blockers. Repetition is the key to mastering. Schottky's ring is typically associated with a sliding hiatal hernia and reflux. So if it's symptomatic, you want to treat it with dilation of the ring and what? Treat the underlying cause, right, which is GERD, so usually a PPI. So found incidentally on EGD, you can just treat with a PPI and no necessarily dilation. But if they're having kind of dysphagia, they're symptomatic, they usually dilate. Leiomyomas, these are a benign esophageal lesion located usually within the muscularis propria, typically in the lower 2/3 of the thorax. Does not require biopsy if no other concerning features or risks of malignancy. Esophageal resection is via enucleation if it's greater than 5 centimeters or symptomatic. And again, the best approach for the lower 2/3 or at least mid esophagus is going to be through what? Right chest. Esophageal manometry interpretation. I'll just leave this up here for reference. Dr. Maneri went through some of this. Zenker's diverticulum, true or false? It is a false diverticulum, correct. And typically loaded posterior and on the left. Occurs between the pharyngeal constrictors and cricopharyngeus muscle, also known as Killian's triangle. Symptoms, again, going to be dysphagia. They usually give a history of choking or halitosis in the question stem as well. Diagnosis is first done with a swallow study. Everyone's tempted always to do an EGD first, but you risk perforation in theory. So we're supposed to do a swallow study first and then scope. Treatment, the key component, no matter what you do, is the myotomy, right? Cricopharyngeal myotomy. Now, resection versus transoral myotomy. Resection versus transoral myotomy and stapling. The incision, if you're going to do it surgically for resection, is going to be through the left neck, right anterior to your sternocleidomastoid. Size criteria I would keep in mind, again, debatable based on your reference, but it's got to be at least 2 centimeters for you to even consider stapling. Otherwise, it's too small to even get your anvils in, right? Some people will say 3 centimeters. So I think on ABSITE, they're probably going to give you small 2 or less, or probably something like 4 or 5. What's the downside of stapling a large Zenker's diverticulum? Higher risk of leak, right? It's just a longer staple line. Don't necessarily overthink it. Division of the cricopharyngeus, and you can consider only pexing that diverticulum in a really moribund or older patient. All right, other esophageal factoids would be related to perforation. Usually it's going to be in areas of anatomic narrowing. So up top, it's going to be the cricopharyngeus, and the most common reason for perforation is, again, unfortunately, going to be from us and iatrogenic, typically through an EGD. I guess we can blame GI. We'll blame GI, not necessarily surgery. Compression of the left mainstem bronchus and aortic arch would be another potential site, although rare. And then Boerhaave's is typically where? Typically down near the GE, just above the GE junction, and left and posterior as well. Diagnosis, gastrograph and swallow first if you're not given a CT. Conservative management, if no systemic effects, consider just MPO, IV fluids, broad spectrum antibiotics. Surgical approach, again, depending where this perforation is, ways to access the esophagus. For the cervical esophagus, it's easier through the left neck. For that upper 2/3 or mid esophagus, it can be easier through the right chest, right? You're avoiding your aorta. And in the lower third, via the left chest, kind of a posterior thoracotomy, or consider laparotomy if it's right there at the GE junction as well. Yes, there is a role for stenting and surgery. And again, kind of a gray area, and I would say surgeon and institution dependent. So something to consider, but they're giving the option for either. Again, go back to the question stem and see what they're really hinting at. Gynecology, everyone's favorite. So ovarian torsion, ultrasound is going to be your initial imaging of choice. Because not only to diagnose it, but also to look at the vascular viability of the ovary as well. In a postmenopausal patient, what's the treatment? Just take it out, right? Salpingo-oophorectomy, and that's most likely because it's an adnexal mass or cancer that's causing this torsion. If they're premenopausal, do not take out the ovary. It's a trick. Don't even think about it. Just cross it out, right? They do not want you taking out any premenopausal ovaries, right? So detorse it. Cystectomy, if it's greater than 5 centimeters, because it's cysts greater than 5 centimeters that have the higher incidence of causing that torsion, in consideration of pexy, but do not take out a young girl's ovary, please. Tubo-ovarian abscess, for some reason they actually tested on this 1 year, and that's why I put it in this slide. Less than 7 centimeters can usually just be treated with antibiotics alone. If it's greater than 7 centimeters, then they usually need percutaneous drainage or surgical drainage. So 7 would be the number to keep in mind. In postmenopausal patients, also think of resection or surgical, at least inspection and drainage, because of the risk of malignancy. Krukenberg tumors or stomach metastases that have dropped down to the ovary. In pathology, they're going to give you signet cells and say, where was this primary source from? And that's going to be the stomach. Meeks syndrome, anyone want to take a shot at this? An ovarian fibroma that leads to ascites and pleural effusion, or typically a right hydrothorax. And that's from an increase in VEGF within that fibroma. Appendicitis in pregnancy, there's the risk of premature delivery in the 3rd trimester, about 9%, and an increased risk of fetal mortality, about 1.5 to 6%. Ideal time would be your 2nd trimester. Unfortunately, we don't get to pick, right, when they get appendicitis and sometimes acute cholecystitis. But in the 2nd trimester, you're almost safe for surgery. Don't worry about it. In the 3rd trimester, think about the risks of fetal mortality and premature delivery. But do what you have to do. Save mom, right? Endometriosis, if found incidentally in the OR, in real life, take pictures and or consult GYN. Hopefully they give you that option to consult GYN intraoperatively, although I doubt you'll see that option choice. But the treatment that they're going to hint at is just hormonal therapy. If they're giving you kind of relatively young female with these kind of vague symptoms and a brownish or bluish mass found somewhere, it's probably endometriosis. Can also involve the rectum and present with intermittent rectal bleeds, irregular menses, and pelvic pain, especially during the time of menses. All right, switching over to urology. Testicular cancer. They really like the kind of pathophysiology here more than anything else. What biomarkers should we test when concerned for testicular cancer? Good. Right. AFP and beta HCG, here be the two. LDH is also significant for prognosis. You have elevated LDH, it's usually a higher tumor burden, more metastatic disease. Seminoma overall is going to be your most common testicular cancer. It's going to have negative AFP, right? And about 10% will have elevated beta HCG, but the key thing is a negative AFP means it's a seminoma. Seminomas are good, as we'll talk about, because they're radiosensitive. Non-seminomatous teratomas, choriocarcinomas, yolk sac tumors, these are going to have elevated AFP and beta HCG. The treatment begins the same for both. It's a radical inguinal orchiectomy, no biopsy, and never transscrotal, right? Because you want to resect that kind of lymph node basin with it. Then you could further stage it with a CAT scan of chest, abdomen, pelvis. And this is looking for more metastatic disease or pelvic adenopathy. Seminoma, as I mentioned, is going to be the most radiosensitive. So they usually just get treated post-op or adjuvantly with chemoradiation. More advanced disease and node positive can get BEP therapy or bleomycin, etoposide, and platinum chemo. Retroperitoneal lymph node dissection, very controversial and questionable. So I don't think it'll be fair for ABSITE or for general surgery residents, but used primarily in non-seminomas and some stage 1 seminomas, but again, controversial. Testicular torsion is a surgical emergency. These always go to the OR. Don't waste your time and get a testicular duplex. Just go to the OR and detorse it, and then you can look at the vascular viability afterwards. Treatment is also bilateral orchiopexy, right? So it doesn't happen to the other side. Prostate cancer most commonly affects the posterior lobe. A normal PSA is less than 4, just if they don't give you that reference on ABSITE. Increased alkaline phosphatase worrisome for metastatic disease to the bones. Renal cell carcinoma, the most common site of metastasis is your lung. And the most common risk factor is smoking. There's one interesting question stem one year about a left varicocele. And why may that actually be an obstructing renal cell carcinoma? Excellent. Yep, left gonadal vein drains to that left renal vein. All right, orthopedic surgery, bone break, fixed bone, hip dislocations. They like to know what anatomy is at risk with these orthopedic injuries is really what they're trying to test you on. So with hip dislocations, most of these are going to be posterior. The patient will have internal rotation and an adducted thigh. Risk of avascular necrosis if you delay the reduction, and there's a risk of nerve injury with the posterior dislocation. Femoral neck fracture, they're going to have a shortened limb and external rotation, also a risk of non-union and avascular necrosis. Difference in femur fractures between adults and peds. We operate on adults. They usually get early operative reduction and internal fixation, so you can mobilize them easier and decrease that incidence of fat embolization. For peds, you just cast them, or what we call a closed reduction, right? Because you don't want to interfere with their growth plates. The unhappy triad of O'Donoghue is a lateral blow to the knee, usually, that they'll give in the question stem, and that's going to be an injury to your ACL, MCL, and your medial meniscus. For posterior knee dislocations, this one's a frequently tested one. It's probably the most important one within the ortho slides I have here. You have to kind of assume that they have a popliteal artery injury until proven otherwise. You can get an arteriogram to rule out vascular injury. At least start with an ABI. Shoulder dislocations, conversely, these are more common anteriorly and also involve a risk of axillary nerve injury. For midshaft humerus fractures, you risk wrist drop and poor wrist extension due to injury to your radial nerve. A Volkmann's contracture is a supracondylar humerus fracture, and that's from compromise to your anterior interosseous artery. Deputane's contracture of your palmar fascia. Usually show you a picture of this. Usually just treat that with steroids and some physical therapy. Rarely would you need a fasciotomy. And that would not be in the scope of a general surgery resident, more of a hand surgeon. Scaphoid fracture, falling on an outstretched hand, usually a tender snuff box, but a negative x-ray. Why may they have a negative x-ray, but you want to follow up with a serial x-ray? The biggest risk with these scaphoid fractures is avascular necrosis. It's the least vascularly supplied bone or area of your hand and wrist. Ewing sarcoma is going to be generally a young patient with pseudorosettes on pathology or onion layering, also seen. Treatment there is going to be chemo first, then radiation and plus or minus surgery. Osteogenic sarcoma will have that sunburst pattern or a Codman triangle on x-ray from that periosteal reaction, and generally just treated with doxorubicin. All right, our percentile pearls, which I'll let you guys read on your own time, and we'll get into our questions. All right, first review question. 50-year-old woman who is otherwise healthy reports uncontrolled pain on rounds postoperative day 1 from a large open ventral hernia repair. Currently has a dilaudid hydromorphone PCA, however not controlling her pain. Which of the following can be considered to improve her analgesia? All right, let's see what we answered. Excellent. Ketorolac or IV NSAID, try to avoid narcotics whenever able, right? Gabapentin may be another alternative answer here as well. Yes, you could do local administration of lidocaine, but again, that's only going to be temporary, and usually don't do that recurrently or repeatedly post-operatively, right? So the best available answer choice, right, for sometimes test-taking strategy as well, is going to be Ketorolac. Please never give a benzo for pain, right? It has no analgesic effect. So E would be an easy one to cross out. All right, next question. We didn't talk about this, but I wanted to at least briefly touch on it. Surgical resident diligently completing their online hospital training modules without preparation for new defibrillators that are going to be deployed around the institution. Despite this time-consuming task, the resident should identify that completing this course represents which of the following ethical principles? Love ethics. Going to be a tough one. Okay, good. Majority of you did actually get it. Non-maleficence or do no harm. That's not only from a technical standpoint, but also educating yourself to do the right thing or to do no harm also counts. Good. Tough one here as well. I didn't know how else to put this, so just made it a question here. 40-year-old male sustains a severe TBI as a result of a motorcycle accident. He now meets indications for feeding tube placement, but can't make his own medical decision. In the absence of a court-appointed guardian or legal power of attorney, which of the following would be the most appropriate substitute decision maker for consent? What's that kind of hierarchy of decision making and consent? Good. Mother, age greater than 60. So divorced spouse, they lose their rights. New partner for 6 months. Most common law marriages have to be, or common law arrangements. Again, it is state dependent, but generally it's going to be 12 months at least. Daughter would be great, but they have to be age greater than 18. So mother, the second best answer choice then would then be the brother, age 45, if you couldn't get in contact with mom. It's tough to study for these ethics and these kind of questions, to be honest. These are those random ones that you just have to kind of get lucky. All right, if there's any questions, please put them in the Q&A box. In the meantime, I'm going to tee up our next lecture, which is going to be breast. And beyond statistics, this was my least favorite topic on ABSITE and oral boards. But I could think of no better faculty member to teach and educate you all today than Dr. Deanna Dixon-Whitmer. I'm going to welcome to the stage now. All right.
Thank you, Jason.
You are welcome. So I'm going to leave you this.
Okay.
I'm going to take this. And we'll show. I'll talk on the next slide. What you wanted in there.
Thank you. So 940 people registered for this.